Welcome back to the Deep Dive, where we extract the absolute essentials from daunting technical material, helping you quickly become well-informed and confident on critical topics. Our mission today takes us into a field of medicine that is, well, it's challenging, it's complex, and it is desperately in need of more attention. Envenomation.
This is a deep dive into genuine clinical urgency. I mean, if you're a medical student or a clinician and you're preparing for work in almost any part of the world, especially the tropics, you need a bulletproof framework for tackling venomous bites and stings.
Exactly.
So we're going to be taking the comprehensive management frameworks, primarily focusing on the principles laid out in advanced clinical texts like Davidson's medicine, and really just distilling them down into high-yield, memorable clinical anchors.
Our goal for you today is pretty simple. We're not just going to be learning facts about snakes or scorpions. We want to build a cognitive template. We want to equip you with the essential clinical structure to recognize a developing crisis and, confidently initiate treatment. And it doesn't matter if you're dealing with a saw-scaled viper in West Africa or a recluse spider in North America. The principles are the same.
And we have to begin with a crucial framing of the topic. Envenomation is so much more than just a localized injury. The World Health Organization now recognizes this global health crisis, particularly snakebite, as a neglected tropical disease.
An NTD.
Right, an NTD. And what that means is that it overwhelmingly affects the poorest populations, often those people without reliable access to effective health care. The necessary countermeasures, like antivenom, are often scarce or just plain inadequate.
That designation alone really speaks volumes about the human cost, doesn't it?
It does.
And our key clinical anchor for this entire session, which I think separates good clinicians from great ones, is this. Envenomation should be viewed and managed as a venom-induced disease, a VID.
VIDI. I like that.
It's caused by the injection of sufficient venom to cause, deleterious local or systemic effects. We are treating the syndrome the venom creates, not merely the bite mark.
Precisely. You're treating the disease. So let's start by just trying to grasp the immense scale of this global disease.
Okay, so let's begin with the biggest picture, the sheer scale of this VID. We know envenomation is the injection of sufficient venom. And that venom, it's an evolutionary tool, right? It's primarily for prey acquisition.
Exactly. It's designed to quickly immobilize and actually pre-digest a victim. Defense is typically a secondary function.
But these accidental human encounters are just tragically frequent, and they're predominantly in these rural agricultural settings all across the tropics.
The numbers are truly staggering, and they're almost always underestimated. Snakes, for instance, hold the grim title of the most impactful group globally. We're talking upwards of 2.5 million cases.
2.5 million?
And over 100,000 deaths every single year. And you have to remember, these are minimum figures. They're usually based on what gets reported from hospitals.
Right.
When researchers actually go out into the community, those numbers just swell dramatically.
That's such a crucial distinction, because when you look at those local studies, the picture just gets darker and darker.
Take India, for example. Recent, more rigorous community surveys suggest that there are at least 45,000 snakebite-related deaths annually.
45,000.
And maybe even significantly more. That far exceeds what was historically recorded in the official statistics. And this isn't just a medical tragedy, it's an economic one. Snakebite disproportionately affects young, healthy adults. Farmers, agricultural workers.
So breadwinners.
Yeah. It rips breadwinners out of the most vulnerable families, and that cements its classification as a poverty trap and, of course, a neglected disease.
So snakes are the big global killers. But we have to address the second most significant group, the ones that are really impacting health systems on the ground.
That would be scorpions. We estimate over 1 million cases annually worldwide. Now, thankfully, the death toll is lower, under 5,000 estimated deaths. But that number doesn't reflect the burden on the healthcare infrastructure.
Right.
In specific regions like North Africa and the Middle East, the high volume of severe neurotoxic scorpion stings, it impacts their health systems and emergency rooms more intensely than snakebite does. And scorpion stings cause very high morbidity and mortality in young children, which puts this immense pressure on critical care facilities.
We also have those, the rare but terrifying events. Spiders, cone snails, blue-ringed octopuses, Australian funnel web spiders. These animals, they rarely interact with humans.
But when they do,
the outcomes are highly likely to be severe or even lethal, and they demand that immediate, specialized intervention.
And before we move on to the venom components themselves, we have to solidify one core clinical concept that saves patients from unnecessary intervention. It's our first concept anchor, the dry bite.
Why is this concept so essential for, say, a first or second year medical student to grasp?
Because venom is metabolically expensive. It takes the animal an enormous amount of energy to produce and store.
I see.
So if a snake or a scorpion is biting defensively rather than hunting, it often minimizes its venom expenditure. This means that a visible bite mark or a confirmed interaction does not automatically mean a significant envenomation has occurred.
So not every bite is a venomous bite.
Exactly. Many defensive bites are dry bites. And this really emphasizes the necessity of repeated clinical assessment over the first 24 hours, rather than jumping to aggressive treatment just based on the history of the bite.
Okay, so let's unpack the actual chemical warfare agents here.
Huh.
If we are treating a venom-induced disease, we need to know the specific functional groups of toxins that cause that disease. Venom isn't a single simple poison.
No, it's a multi-component cocktail, a very complex one. And we have to master the 8 key categories of effects. We can even group them mentally, say, into immediate systemic threats and then the local or organ system destroyers.
I like that. Okay, let's start with what you call the fast killers, the ones targeting the nervous system and the heart.
Right. Number 1, neurotoxins, the nerve jammers. These are perhaps the most acutely lethal because they target the pathways controlling our breathing.
Yeah.
And as you noted, they have 2 main presentation patterns.
Okay.
First, you have the paralytic toxins, which cause flaccid paralysis. This is a progressive limpness that leads to respiratory failure. The critical distinction here is the pattern of onset.
The pattern.
Yes. Many snakes like kraits, mambas, and also cone snails and the blue-ringed octopus cause a descending paralysis. It starts in the face and it moves downward.
Top down.
Exactly. Conversely, toxins like those from paralysis ticks cause a unique ascending paralysis. It starts in the legs and moves up toward the diaphragm, and it often presents with early gait instability or ataxia.
And the second neurotoxic flavor is, what did you call it? The autonomic storm.
Yes, the excitatory toxins. This is a complete system overload.
It sounded.
It is. These toxins, which are characteristic of many scorpions, like the Indian red scorpion, funnel web spiders, and irukandji jellyfish, they essentially lock the nervous system into overdrive.
Oh.
The result is a massive, uncontrolled release of catecholamines, which effectively creates a sympathetic storm. Clinically, this manifests as wild fluctuations in heart rate and blood pressure, leading rapidly to cardiac dysfunction and potentially lethal pulmonary edema. This mechanism is one of the most important concepts in scorpion envenomation.
Wow. Okay, so next let's move to the secondary but still devastating systemic and local destroyers. I mean, these are often the effects that lead to long-term morbidity or secondary mortality, typically from things like kidney failure.
Exactly. So, number 2, myotoxins, the muscle shredders. These cause myolysis, the breakdown of skeletal muscle tissue, which can be local or systemic.
And what happens when the muscle breaks down?
When muscle cells are destroyed on a large scale, they release their intracellular contents, including myoglobin, and this myoglobin is toxic to the kidneys. It often leads to acute kidney injury, or AKI.
And where do we see this?
You see this with some key viper species and also with kraits. The patient might complain of, generalized muscle pain and tenderness that might seem nonspecific, but it's a precursor to renal failure.
And working alongside these, we have the direct damage to the circulatory system itself.
Number 3, cardiotoxins, the heart attackers. These components can be directly toxic to the heart muscle, or they can cause profound shock indirectly, which results in cardiac collapse. Box jellyfish venom is a classic example of rapid cardiotoxicity. It often causes death within minutes.
Terrifying.
It's also a major feature of severe envenoming by snakes, scorpions, and funnel web spiders.
Now, for what might be the most common effect we see globally, disruption of the body's ability to clot.
Right. Number 4, hemostasis system toxins, the clot disruptors. Now, this is highly complex. Most of these toxins are actually procoagulants.
Procoagulants, so they cause clotting.
Yes, they activate the body's clotting cascade massively and inappropriately. This rapid consumption of all available clotting factors, fibrinogen, platelets, everything, means that the body is left with nothing left to clot with.
And the result is?
A severe, generalized, spontaneous bleeding syndrome. This is the main pathology we see with Russell's vipers and saw-scaled vipers. Less commonly, certain venoms can cause thrombosis and PE, which is rare but an important presentation to be aware of.
And complementing that is the structural damage caused by the...
Mm.
Number 5, the hemorrhagic toxins, the vessel leakers. How do these differ from the clot disruptors?
So while the clot disruptors empty the clotting factor pantry, the hemorrhagic toxins destroy the container itself. They directly damage the walls of the blood vessels. And this leads to local bleeding, fluid extravasation, massive bruising, we call it ecchymosis, and blistering. On a systemic level, severe vascular damage leads to capillary leak syndrome, where fluid just leaks out of the vessels into tissues, resulting in profound hypertensive shock. These are primary features of many viper venoms.
Moving to organ-specific destruction. Number 6, nephrotoxins, the kidney killers.
Kidney damage, or AKI, is a major cause of late death and long-term morbidity. It can be caused in 3 ways. Directly by the venom, indirectly by that mass release of myoglobin from myolysis we talked about, or secondary to prolonged shock and hypoperfusion of the kidneys. Clinically, you have to aggressively manage fluids and monitor urine output to protect the kidneys, especially after snakebite or mast stings from bees or wasps.
Then we have the toxins that destroy tissue locally, causing that horrible long-term disability.
Number 7, necrotoxins, the flesh eaters. These cause local tissue injury and necrosis. The initial bite might not seem severe, but the progressive local destruction leads to massive tissue loss, potentially requiring skin grafts or even amputation.
And which animals are the main culprits here?
Key offenders are cobras in Asia, the Iranian Hemiscorpius scorpion, recluse spiders, stingrays, and many stinging fish and jellyfish. This is a major, major source of chronic morbidity.
And finally, the reaction they can kill in minutes.
Right. Number 8, allergic toxins. While any venom can be allergenic, the social insects, bees, wasps, ants are the main drivers of severe allergic reactions. Death here is usually due to acute anaphylaxis, bronchospasm, and circulatory collapse, rather than the systemic toxicity of the venom itself.
Unless
the patient suffers a massive swarm attack, of course.
Okay, so the key takeaway for Section 1. Venom is a multifaceted weapon. A single envenomation often causes multiple simultaneous syndromes. You could have neurotoxicity and coagulopathy at the same time.
Exactly. And while snakes are the primary global mortality risk, scorpions cause high morbidity, especially in children, and they really should be viewed as locally critical public health problems.
Before we move on to the physical exam, let's just use this moment for a quick check-in. This is really crucial for guiding management later. You just learned about the 2 patterns of flaccid neurotoxic paralysis. Wait, let me make sure I got that. For flaccid paralysis, you mentioned 2 patterns. What were they, and what are the key animals associated with each one? If you couldn't instantly recall the descending pattern, that's snakes and octopuses, and the ascending pattern from ticks, please just rewind and listen to the neurotoxin segment again. This distinction is absolutely vital for diagnosis.
It really is.
Now that we understand the toolbox of toxins, let's walk through the assessment of the patient, say, in the clinic or the emergency room. We categorize the clinical effects into 3 groups, and this helps guide our immediate management.
First, you have the local effects. These are often what the patient is focused on. The pain, the swelling, blistering, bruising. But here is our anchor. Minimal local effects do not rule out lethal systemic envenoming.
That feels like a trap.
It is a massive clinical trap. You have to educate the patient and yourself on this. A crate bite in Asia, for instance, can be almost painless with minimal swelling, yet it can lead to fatal respiratory paralysis hours later.
So the local effects only tell you something bit the patient.
That's it. They do not dictate the systemic risk.
Okay. Second are the general systemic effects. These are the nonspecific constitutional symptoms that signal something major is happening inside. Headache, severe nausea and vomiting, abdominal pain, or even sudden collapse.
And the most dangerous general effect is shock. Shock, presenting as hypotension and poor perfusion, is a potentially lethal complication. It can result from severe local fluid shifts, where massive swelling literally pulls fluid out of the circulation, or from general systemic compromise due to cardiotoxicity or capillary leak syndrome.
And children are especially vulnerable here.
Extremely. They are particularly vulnerable to rapid decompensation from shock. Early fluid management is absolutely non-negotiable.
And third, and most diagnostically important, are the specific systemic effects.
Right. These are the clinical syndromes we are actively looking for as they mandate immediate anti-venom administration or advanced supportive care. So, paralysis, coagulopathy, myolysis, indicated by muscle pain or dark urine, or that neuroexcitation, the autonomic storm.
Okay, now for the physical exam. This has to be systematic, and the source material really anchors us to the most critical early markers. And we are heavily focused on the cranial nerves. You call them the early warning system.
Yes.
Why are the cranial nerves the gold standard early indicator?
Because the paralysis so often develops in a predictable descending pattern for many dangerous neurotoxic snakes. The cranial nerves controlling eye movement, speech, and swallowing are affected first. Clinically, you are looking for drooling, slurred speech, dysarthria, difficulty swallowing, dysphagia, and any signs that the upper airway is starting to compromise. The progression can be terrifyingly fast.
And the single most critical finding, the anchor that should set off alarms in any clinician's mind, is in the eyes.
That is bilateral ptosis, the drooping of both eyelids. This is often the first observable sign of descending neurotoxic flaccid paralysis, and it is your red flag for urgent intervention. This sign should be monitored as frequently as vital signs, perhaps every 15 minutes initially.
And as it progresses,
As the paralysis progresses, you'll see ophthalmoplegia, which is difficulty moving the eyes, and eventually, in the most severe cases, fixed dilated pupils. We're also looking for other signs of that sympathetic storm, like piloerection or profuse sweating.
and the paralysis just continues to descend,
Yeah.
affecting major muscle groups.
Correct. After the eyes and the throat, the neck muscles follow. Paralysis extending to the neck causes the patient to be unable to hold their head up. We call it the broken neck sign.
Wow.
This is usually the penultimate stage, followed finally by respiratory paralysis affecting the diaphragm and intercostal muscles, which will require mechanical ventilation to save the patient's life.
Beyond the head and neck, what else must we assess thoroughly?
We have to check for signs of myolysis, generalized muscle weakness, pain, and tenderness. Remember, this indicates muscle breakdown that precedes kidney damage. You should check deep tendon reflexes. Decreased or absent reflexes are consistent with paralysis extending to the limbs. And don't forget the skin.
Okay.
Look at the bite site for progression of local damage pain, swelling, blistering necrosis, and check for enlarged, tender regional lymph nodes, which indicate significant lymphatic absorption of the venom.
So given that envenomation disproportionately affects these resource-poor settings, a quick, reliable, standardized test for coagulopathy is essential. It often has to replace a full lab screen, and this is the 20-minute whole blood clotting test, the 20-WBCT.
The 20-WBCT is a fundamental tool for managing many dangerous viper bites, like Wessel's vipers, saw-scaled vipers, which rely on procoagulant venom. Its accuracy is high, but only if performed correctly.
Okay, walk us through the exact procedure. It has to be standardized to be reliable.
Right. First, blood collection. You need 2 to 3 millioils of venous blood. Crucially, it must be placed in a clean glass container. The source emphasizes a test tube or a small bottle that has been washed only with water, not with soap or detergent, which can interfere with the clotting process.
Okay, that's a key detail. No soap.
No soap. Second, the wait time. You have to allow the container to stand absolutely undisturbed for the mandatory 20 minutes. Don't move it, don't shake it, don't disturb it.
Got it.
Third, check. Gently invert or tip the container. And fourth, result interpretation. If the clot is absent, that is a positive test. This indicates major consumptive coagulopathy is present, and it often mandates immediate antivenom administration. If a firm, solid clot is present, the test is negative for this type of coagulopathy.
It's an ingenious, low-tech way to detect a life-threatening syndrome. And finally, what essential information can a simple urine examination provide?
Dark urine, often described as Coca-Cola colored, is a critical sign. It strongly suggests myoglobinuria, confirming widespread muscle breakdown, or rhabdomyolysis. This tells you the patient is at imminent risk of AKI and demands aggressive fluid resuscitation.
And if you see blood?
If you see blood in the urine, that's hematuria, which strongly suggests a major bleeding syndrome due to coagulopathy. These simple clinical checks are absolutely life-saving diagnostic anchors.
Okay, now for that terrifying clinical scenario we discussed earlier, the ultimate clinical pitfall. You have a patient presenting with that constellation of severe neurotoxic signs: bilateral orgiotosis, fixed dilated pupils, absent reflexes, lack of movement, but they're still able to maintain minimal respiration, maybe with some help. What diagnosis might a rushed, fatigued clinician immediately jump to, and why is that so horrifying for the conscious patient?
The clinician might mistakenly diagnose irretrievable brain injury given the fixed pupils and absent reflexes. But the text warns us this is a classic trap in severe neurotoxic envenomation. The patient is often fully conscious, fully aware, and terrified, trapped inside a paralyzed body that cannot communicate.
That's unthinkable.
It is. Failing to recognize the signs of reversible or temporary paralysis means you might mistakenly withdraw life support. We must be absolutely sure we exclude neurotoxic flaccid paralysis before confirming brain death.
That moment just reinforces the critical importance of a systematic approach.
Absolutely.
Moving directly from assessment to intervention, let's start with what happens immediately after the bite first aid. The guiding principle for managing the field response, particularly for snakebite, is our first anchor. Stillness is key.
It is the single most effective first aid measure globally. Remember, many venom components, especially those larger protein toxins, travel via the lymphatic system, not the blood circulation, to enter the systemic circulation.
So movement is bad.
Movement acts like a pump for the lymphatics. Therefore, keeping the patient absolutely still and immobilizing the bitten limb with a splint significantly delays the systemic spread of the venom.
What about pressure bandages, like the pressure immobilization bandage or PIB? When should they be used?
PIB is a highly specific intervention. It's generally recommended for elapid bites like those from Australian snakes and kraits, where the venom is primarily neurotoxic and spreads quickly via the lymphatics. A local pressure pad is also recommended in places like Myanmar for specific vipers.
But it's not a universal fix.
No, this technique is not universally recommended for all envenomations, especially those involving massive local necrosis where pressure can actually worsen the local injury.
This brings us to the danger zone. Ineffective or dangerous first aid. This is perhaps the most crucial section for correcting dangerous misinformation. What must we strictly avoid?
We must strongly advise against suction devices, cutting the wound, applying local chemicals, using traditional snake stones, or electric shock. These interventions are useless and they waste critical time.
But the most serious warning is about the tourniquet.
Yes.
Why are tourniquets so disastrous in the context of snakebite?
There are two major risks. First, if they're applied incorrectly, too tightly, or left on too long, they guarantee catastrophic distal limb ischemia, which often leads to amputation and long-term disability regardless of whether the venom itself caused damage.
Yeah.
You're just replacing one medical emergency with another.
And the second risk?
The second, an acutely lethal risk, is upon removal. If a tightly applied tourniquet has bottled up a large amount of venom, its sudden removal releases a massive bolus of toxins into the systemic circulation all at once. This can trigger rapid, fatal cardiorespiratory collapse.
So rapid transport with the limb immobilized, that's the universal goal. Once the patient arrives at the hospital, what are the two immediate priorities?
Priority 1 is the ABC priority. Resuscitation comes first. You must immediately identify and treat life-threatening problems. Is the patient in shock? Do they have respiratory failure requiring intubation? Are they having a major hemorrhage? Is there impending limb compromise from an incorrectly applied tourniquet that needs controlled removal?
Life support before specific treatment.
Always. Priority 2 is the diagnosis of significant envenomation. This relies on the comprehensive history and the systematic physical exam we just discussed.
Right.
The history has to capture the when, what, and where of the bite, and critically, what first aid was applied and when the symptoms began. If the patient is initially normal, they must be observed repeatedly, often for 24 hours, as symptom onset, particularly neurotoxicity or coagulopathy, can be significantly delayed.
Once we have confirmed a significant systemic envenomation, the discussion immediately turns to the centerpiece of treatment, antivenom or AV.
Antivenom is the most specific and important therapeutic intervention. It's typically produced by hyperimmunizing animals, usually horses, which then generate antibodies that are purified and infused into the patient. These antibodies bind to and neutralize the circulating venom toxins.
But it's not a panacea. When is AV indicated?
The indications are clear and urgent. General indications include any sign of systemic collapse, shock, cardiac collapse, rapidly progressing local swelling that threatens limb viability, or uncontrollable systemic bleeding.
And the specific ones?
Specific indications target the diagnosed syndromes. Developing paralytic features, especially that bilateral litosis, evidence of rhabdomyolysis or AKI, a positive 20W-BCT indicating coagulopathy, or severe neuroexcitatory envenoming, like with scorpion stings.
Now, for what might be the most important high-yield concept in this section, understanding the time factor and paralysis using that pre- versus post-synaptic lockout metaphor. This explains why antivenom works for some paralysis, but not others.
This is absolutely fundamental. We're talking about the neuromuscular junction, the NAJ, which is where the nerve signal meets the muscle cell. Venom targets this communication line in two ways.
Okay, let's start with the one where AV has the best chance, the postsynaptic blockers.
Right. Think of these toxins, like those from some cobras, as a sticky patch placed directly over the electrical outlet, the acetylcholine receptor, on the muscle side. They physically block the natural neurotransmitter AT from binding.
So they're blocking the signal from getting through.
Exactly. But critically, this is an external block that does not cause structural damage to the nerve terminal. Since the problem is external and potentially reversible, antivenom can sometimes get into that junctional space, grab the sticky patch, the toxin, and reverse the paralysis. We see rapid, sometimes dramatic reversals in these cases if AV is given promptly.
Okay, now for the terrifying scenario. The presynaptic destructors, which are common in crates and taipans.
These toxins target the nerve terminal itself, so they're not just blocking the outlet, they are actually entering the nerve cell, disrupting the machinery that makes and packages a key, and eventually they cause severe, irreversible structural damage to the motor neuron axon terminal.
They break the machinery.
They break the machinery. And once this physical damage is done, antivenom will not reverse the established paralysis. The nerve terminal has to physically regrow and repair itself, a process that can take days or even weeks.
So the critical anchor here is
Antivenom must be administered before significant paralysis occurs, especially when a presynaptic toxin is suspected. Once the presynaptic damage is done, the antivenom can only prevent further toxin from reaching other healthy nerve terminals. It can't fix the ones that are already broken.
regarding coagulopathy reversal, AV is excellent, but we need to be patient. Why is that?
Well, AD neutralizes the toxins that are circulating in the blood. For coagulopathy, this stops the destruction of clotting factors. However, the patient must still wait for the body, primarily the liver, to regenerate all those consumed clotting factors.
And that takes time.
That process takes time, often several hours. Therefore, a clinician should not redose antivenom simply because the 20-WBCT hasn't normalized in the first 1 to 3 hours after the initial dose. Immediate redosing is typically reserved for signs of continuing systemic toxicity, like worsening paralysis or shock, not just slow factor regeneration.
Right, and antivenom is just one tool. Let's talk about the vital non-antivenom support.
For patients with postsynaptic paralysis, we can sometimes use anticholinesterases, like neostigmine. These drugs inhibit the enzyme that breaks down AC, thereby increasing the amount of neurotransmitter available in the NMJ.
So it boosts the signal?
It boosts the signal. While it's not a standalone cure, it can sometimes boost the remaining receptors and improve symptoms, acting as an adjunctive treatment.
What's the preferred drug for managing that autonomic storm of a severe scorpion sting?
In regions like India, where the Indian red scorpion causes severe cardiotoxicity, prasin, an alpha-adrenoceptor antagonist, has been utilized to counteract the massive catecholamine release. It effectively reduces hypertension and pulmonary edema. While specific antivenom is now the gold standard in many areas, supportive anti-adrenergic therapy remains critical when AV is unavailable or delayed.
And the ultimate resource-intensive supportive measure for neurotoxicity.
Mechanical ventilation. If the respiratory paralysis is established, especially if it's due to a destructive presynaptic toxin, the patient may require assisted breathing for a prolonged period.
And not just for days.
No, not for days. The source material notes patients sometimes require ventilation for several months until the nerve terminals can repair themselves. This long recovery time is a major factor driving that NTD classification in low-resource settings.
Finally, a surgical warning emphasized by our source material, the use of fasciotomy.
Fasciotomy is often grossly overused in snakebite, and it can lead to disastrous functional outcomes. It's a procedure for confirmed compartment syndrome, where massive swelling cuts off circulation. But before even considering it, the clinician must exhaust non-surgical options like limb elevation and antivenom administration.
And most importantly,
They must ensure the patient's coagulopathy has been completely reversed. Performing surgery on a patient who cannot clot is a major hemorrhage risk. You should only use this procedure as a last resort.
Okay, the key takeaway for Section 3. Field management requires stillness and immobilization, avoiding the catastrophic risk of tourniquets. In the hospital, the priority is life support ABCs. Antivenom must be given urgently, but recognizing the two types of neurotoxicity is key to predicting its effectiveness and preparing for prolonged supportive care, particularly ventilation. Let's check in again. Imagine you've just administered antivenom to a patient with severe coagulopathy. If the 20 WBCT is still positive 3 hours later, should you immediately give a second dose of antivenom? If not, why? The answer is no, because regeneration of clotting factors takes time, and the patient may need hours for coagulation to normalize even after the venom is neutralized. Redosing is based on persistent systemic toxicity, not just slow lab normalization.
Perfectly put.
Here's where it gets really interesting, connecting the science to the real-world chaos of clinical practice. If you move geographically, the same species of snake can cause a completely different clinical syndrome. This is the challenge of geographical mismatch, and our source material heavily emphasizes that geography dictates the precise risk.
Absolutely. The clinical risk is wholly dependent on the local fauna. The problem for treating physicians is that the venom composition, the exact ratio of neurotoxins to hemorrhagic toxins to myotoxins, varies widely even within a single snake species. It depends on where it lives and what it preys on.
And that means
It means antivenom raised against venom from one population may be poorly effective against bites from the same species in a different region.
the Russell's viper, the Deboia species, provides the most famous and devastating example of this clinical variability.
Oh, the differences are profound. In Sri Lanka, Russell's vipers commonly cause the full spectrum: coagulopathy, acute kidney injury, and they cause rhabdomyolysis and flaccid paralysis.
Wow.
Now compare that to the Russell's vipers across most of the Indian mainland. They cause severe coagulopathy and AKI, but they typically do not cause rhabdomyolysis or paralysis.
And some South Indian populations add another dangerous syndrome entirely on top of that.
They do. Certain South Indian populations cause a distinct and lethal capillary leak syndrome. The patient presents with profound hypotensive shock and widespread fluid extravasation, which can lead to severe pulmonary edema. Furthermore, this subspecies is also known for causing anterior pituitary hemorrhage and subsequent endocrine failure, a unique long-term complication not seen in other populations.
So knowing your regional viper is absolutely non-negotiable.
It is. And this variability isn't just academic, it dictates antivenom effectiveness. Indian antivenoms, for example, are not effective against the venom of African saw-scaled vipers, the Aechis species.
So what's the solution?
That geographical mismatch is why the WHO strongly encourages clinicians to adopt a syndromic approach, especially in Asia. If the snake isn't identified, which is the case about 80% of the time, we use the cluster of clinical features to guide immediate treatment. It's far safer than waiting for species identification.
Okay, let's anchor this with a couple of key Asian syndromes.
Let's consider syndrome 4A. The patient presents with minimal or no local swelling, but rapidly develops flaccid paralysis, the netosis, the ophthalmoplegia. If the patient was bitten on land, possibly while sleeping, this syndrome points almost universally to a crate bite.
So recognizing that syndrome means you immediately anticipate presynaptic damage.
Exactly. And the urgent need for ventilation support, even if the bite site looks completely trivial.
And what about syndrome 5C? This is one that requires us to think regionally, right?
Right. Syndrome 5C is that complex picture. Variable local effects, flaccid paralysis, dark urine from myoglobinuria, AND coagulopathy, or bleeding. This specific combination of effects points directly to the specific venom mix found in the Russell's viper in Sri Lanka, or parts of South India. If you see the specific triad of symptoms, you know you need an antivenom that targets those specific myotoxins and neurotoxins, which may differ from the polyvalent antivenom used in other parts of the world.
Okay, let's quickly drill down on the most important animal groups in key regions, just to reinforce these syndromic patterns. We'll start with the major snake families: Viperidae vipers and Elapidae cobras and kraits.
Okay, focusing on Asia, while the big four are often taught, we have to address the critical omissions. The hump-nosed vipers, the hypnel species, common in India and Sri Lanka, are a huge problem.
Why?
They cause significant coagulopathy and AKI, yet their venoms are often not covered by the current Indian polyvalent antivenoms. This means treatment may fail, and supportive care for the AKI becomes the primary life-saving intervention. Kraits are the masters of presynaptic flaccid paralysis. Cobras cause paralysis but are notorious for causing devastating local necrosis. And Russell's and saw-scaled vipers cause that profound procoagulant coagulopathy and subsequent renal failure.
Okay, moving to Africa, what are the signature syndromes there?
Africa is home to the fastest neurotoxins, the mambas. Their bites cause rapid neurotoxic flaccid paralysis and shock. Puff adders cause potent coagulopathy, shock, and significant local necrosis, often requiring extensive surgical debridement. The carpet vipers, the Aechis species, cause severe procoagulant coagulopathy and renal failure.
And what about the boom slang?
Ah, the fascinating boomslang. It's a rear-fanged snake, and it causes a delayed but profound procoagulant coagulopathy, demanding a very specific antivenom.
And finally, Australia.
Australia's key species, the brown snakes, tiger snakes, and taipans, all share a powerful classic triad of effects. They are all elapids causing potent procoagulant coagulopathy, severe presynaptic paralysis, and myolysis.
So if you see one, assume all three.
For a clinician in Australia, if you see any one of those three features, you assume all three are present, and you treat aggressively with their specific polyvalent antivenom. Australia's ability to use venom detection kits to rapidly confirm the family of snake involved is a massive advantage in guiding that antivenom choice.
Let's pause for a second check-in question. We discussed the geographical variability of the Russell's viper. If a patient is bitten by a Russell's viper, a daboya, in Myanmar, what critical systemic complication is especially common and severe there? And how does that specific presentation, that clinical syndrome, differ from the same snake found across most of the Indian mainland? The answer is that capillary leak syndrome, hypotensive shock, and severe AKI are highly common in Myanmar Russell's viper envenomation, contrasting with most of India, where rhabdomyolysis and paralysis are typically absent.
Excellent.
Okay, we've established snakes as the biggest global threat, but scorpions are next. For clinicians, managing a severe scorpion sting requires a really distinct approach because the pathology is entirely different. It's not paralysis or bleeding, it's an overload.
That's exactly right. The most medically important scorpions belong to the Buthidae family. Their venom is a highly specific cocktail of neuroexcitatory toxins that target ion channels, leading to that massive system-wide activation, the catecholamine storm-like syndrome.
Describe the clinical presentation of a full-blown catecholamine storm in a child.
It's terrifying, and it's rapid. The toxins cause profuse sweating and salivation. Those are cholinergic effects, followed by extreme cardiovascular instability. We're talking wildly fluctuating heart rates from severe tachycardia to profound bradycardia and dramatic changes in blood pressure.
So it's all over the place.
Completely. And this ultimately leads to pump failure, cardiac dysfunction, and non-cardiogenic pulmonary edema fluid in the lungs. It is rapidly fatal, particularly in children, due to their smaller physiological reserve.
And how is this managed?
Treatment is aggressive and it's region-dependent. Where available, specific antivenoms like those developed in India or South America have shown great success in neutralizing the circulating toxins and reversing the storm. If AV is unavailable, supportive care involves stabilizing the cardiovascular system, often using drugs like prazosin to mitigate the adrenergic effects and mechanical ventilation for the pulmonary edema.
Now, let's revisit that profound exception, which really reinforces the need to know your regional variability. The Iranian scorpion.
Ah, yes, the Iranian scorpion, Hemoscorpius lepidus. This is a vital one to remember for contrast. It's one of the very few scorpions that does not cause neuroexcitation.
So what does it do?
The initial sting is often painless or very minor. The major pathology is delayed. You get progressive local necrosis and a devastating systemic illness that mirrors a hemolytic crisis. Intravascular hemolysis or red blood cell destruction, DIC, and secondary renal failure and shock. It is a slow, insidious killer, unlike the fast-acting Buthidae.
This leads us neatly to spiders, as that slow necrotic syndrome is a classic spider presentation. And we divide the dangerous spiders into two groups, neuroexcitatory and necrotic.
Correct. The neuroexcitatory group causes systemic distress. First, you have the Australian funnel web spiders. These are extremely dangerous, injecting a venom that causes a severe catecholamine storm, often requiring immediate mechanical ventilation and high doses of antivenom, which is highly effective and life-saving.
Okay.
Then you have the widow spiders, which cause latrodectism. This is characterized by agonizing, generalized muscle pain, muscle rigidity, sweating, and hypertension. Antivenom is the cornerstone of treatment for symptom relief. And finally, the banana or wandering spiders in Central and South America, which cause neuroexcitation, severe pain, and sometimes shock.
And in the necrotic group, the most important genus is the recluse spider.
Recluse spiders, Loxosceles, often called brown recluse or fiddleback spiders. Their bite is typically painless, leading to a spreading local lesion, a painful, sinking patch of skin necrosis. Systemically, severe cases mirror that Hemoscorpius syndrome, intravascular hemolysis, and potential renal failure. There's no widely available antivenom for recluse bites, so management is supportive. focusing on wound care and watching for signs of systemic hemolysis.
Next, a fascinating threat because it attacks from the inside out and has that ascending pattern of paralysis. Paralysis ticks.
Ticks are unique. Found in Australia, North America, and parts of Africa, they inject potent presynaptic neurotoxins via their saliva during feeding. This toxin causes a gradually onset ascending flaccid paralysis.
So it starts in the legs.
Exactly. The patient might present with ataxia or just not feeling right, and the paralysis slowly creeps upward, eventually affecting the respiratory muscles.
And the treatment contrast is really important here.
It is. There is no chemical antivenom that works against the tick toxin. The primary treatment is purely supportive. Immediate and meticulous removal of all the ticks. They're notorious for hiding in hair and skin folds. And supportive care, often requiring mechanical ventilation if respiratory function is compromised.
But the prognosis is good.
The prognosis is excellent. Once the toxin source is removed, the presynaptic nerve terminals begin to repair themselves, and the paralysis usually resolves completely within 24 to 48 hours. This time-limited nature is key to management.
Before we wrap up, let's briefly touch on the unique threats from venomous insects and marine life, starting with that unique hemorrhagic threat from South America, the caterpillars.
The lepidopterans, specifically the Lenomia caterpillars in Brazil, possess spines that inject an incredibly potent procoagulant venom. This venom causes a massive, often fatal consumptive coagulopathy, leading to widespread hemorrhage and organ failure. It's distinct from snake venom coagulopathy. Fortunately, a specific Brazilian antivenom is available for this severe, rapid-onset syndrome.
And what about the ubiquitous hymenopterans, the bees, wasps, and ants?
Well, a single sting is usually only locally irritating. The primary danger is severe anaphylaxis. However, when patients are subjected to mass stings, think Africanized bee swarms or large Asian hornet attacks, they receive a high enough venom load to cause significant systemic toxicity.
What kind of toxicity?
We're talking hemolysis, DIC, shock, and multi-organ failure. Management then becomes a dual effort, treating the anaphylaxis and providing aggressive supportive care for the multi-organ system damage.
Finally, the marine environment. We have an easy anchor for initial pain relief here.
We do. The heat rule. Many marine venoms are temperature sensitive. For immediate pain relief from most stinging fish, jellyfish, and stingrays, the initial first aid is simple. Hot water immersion or a shower at about 45 degrees Celsius. This denatures the protein toxins and often dramatically reduces the intense local pain.
Antivenom is scarce in the marine world, only available for a select few.
Correct. Antivenom exists only for the highly dangerous sea snakes, which cause myolysis and paralysis, similar to Australian elapids, the notorious box jellyfish, which cause rapid onset cardiac collapse, and the stonefish, which is known for its intense pain and necrosis.
And what about the lethal marine animals where only supportive care is available?
The blue-ringed octopus and cone snails both inject venoms, causing rapid cardiovascular collapse and severe flaccid paralysis. Because these are often small wounds, the rapid onset of life-threatening systemic effects can be deceptive. For these, immediate and prolonged mechanical ventilation is the only life-saving intervention.
So what does this all mean? We've taken this daunting topic, envenomation, and really distilled it into a set of actionable clinical principles. Managing a patient is fundamentally about recognizing the developing syndrome paralysis, coagulopathy, myolysis, or neuroexcitation, and quickly launching a tailored response.
The identity of the animal is almost secondary to the effects of its toxins.
Exactly.
We've established the non-negotiable aspects of management, prioritizing the ABCs, understanding that critical difference between the reversible postsynaptic blockers and the long recovery presynaptic destructors, and knowing the indications and limitations of antivenom. Overall management is complex. It often requires prolonged life support like ventilation or renal dialysis, not just a simple dose of antivenom.
Let's lock in these 4 final critical anchors for the learner.
Number 1, ptosis is priority. The appearance of bilateral ptosis is the single most critical early sign of descending neurotoxicity, demanding immediate antivenom consideration.
Number 2, 20 WBCT standard. The absence of a clot after 20 minutes in a clean glass tube is a positive test for consumption coagulopathy. It's an essential diagnostic anchor in resource-limited settings.
Number 3, no tourniquets. Avoid this dangerous first aid. It risks catastrophic limb ischemia and lethal cardiovascular collapse upon removal. Immobilization is the superior choice.
And number 4, know your geography.
Venom composition and clinical presentation are highly regional and variable, making a syndromic approach mandatory. Remember the profound clinical differences between Russell's vipers based on location.
We know that presynaptic neurotoxins, like those from crates, cause damage that antivenom can't easily reverse. It can require months of mechanical ventilation while the motor neuron repairs itself. If you were a physician working in a rural, low-resource clinic, facing a patient with rapidly developing presynaptic paralysis, what crushing ethical and practical challenges does that need for lengthy, sophisticated supportive care pose to your extremely limited resources? And how does this daily reality powerfully emphasize why snakebite is classified as a neglected tropical disease? Something truly important for you to mull over until our next deep dive.